So new anymore. Our health officer made a very detailed presentation, and council members had a ton of questions, but we didn't have a ton of time. So today we don't have a ton of time, but I'd like to wrap up no later than 4 p.m. What I find is that each slide triggers a bunch of questions. So what I'm going to urge, it's only Mr. Rice here. I understand Mr. Berliner won't be joining us, but other council members may be. What I'd encourage myself and Mr. Rice to do is make contemporaneous notes as each slide, and then you can write on the packet here, and then we'll just go through all the questions, and I think there will be many. So I want to just offer my warmest words of praise for you, Dr. Gales. It's really been great working with you, and I will say you could plot a learning curve by the difference between your first presentation as health officer to the Board of Health and then this presentation, which, as much as I really esteem Dr. Tillman, was really the best and most thorough presentation that any health officer has made to the Board of Health in my 16 years as chairman of the HHS committee. It was extraordinary. So well done, and lots of praise for you, and let's hear it again in greater detail.
I just want to clarify, because Dr. Gales is always updating things. You have a hard copy that you can follow with these slides, but it's not the same as what was in the packet. We will make a link on the council website to the new presentation so that everybody can access it later today. But if you're trying to follow along with the presentation in the packet, it won't match. But you have something to make notes on there.
Great.
Okay?
Okay, well.
Just one more thing before you begin. Because so much of your presentation relates to disparities, we asked representatives of the 3 minority health initiatives to join us. We're not asking them to present. If questions arise that any of the 3 minority health initiatives would like to answer after the presentation, we won't have questions during the presentation. You're going to make the presentation. Then if any of the questions relate specifically to something that the minority health initiatives would like to comment on, I think rather than calling them up, I see the representatives of the 3 initiatives here. They may seek recognition, and I'll recognize them. We'll have an open conversation, but there may not, I don't know if there will be a need for that, so I don't want to put them in the position of feeling like they must formally react. But if council members have questions, we'll ask them after your presentation. And now please proceed.
Okay. Well, thank you.
Thank you.
And thank you all for the opportunity to have this conversation. I'm excited to be here and excited to talk data and excited to talk public health. So thank you for, last week was my 1-year anniversary, so I've had a good time and enjoyed working with you all. And thank you, the title is talking about innovative data-driven approaches, but the first hallmark in order to be able to launch innovative issues and opportunities is to have innovative ideology and thought and space to do that. So thank you all for creating the space and allowing us to do that. All right, so objectives today, and there will be a little bit of a tweak, so I won't go through the detailed slides that I presented at the full council presentation, but that serves as the underlying infrastructure for what we'll be presenting today and pulls on some of that. So look forward to questions about that as well as it framed within this. So the objectives, we're going to talk about some of our more formal approaches to how we're utilizing data to address public health issues, give a little bit of background about some of our data sharing partnerships and how some examples that we've already put into motion in terms of how we're doing that, and then also share with you a new set of data that builds upon that health report that was presented in July, that breaks the county down within zip codes to understand how we perform intra-county, since we have at least for the last several years, been #1 for the overall county health rankings for the state. We took the analysis to another level and broke that down within the county to look at how the zip codes match up against each other, so that while yes, we will continue to celebrate being #1 in those rankings, we'll actually have a deeper understanding at what that looks like within the county. So again, before starting, I think this is something I do all the time. I like to say thank you before we get started. So deep set of acknowledgments to the HHS staff, everyone behind me collectively, in particular our epidemiology and planning team, Dr. Liu, who's our chief epidemiologist, who spearheaded this project with the zip code analysis, Melissa Marcia, who is a graduate student from the University of Maryland School of Public Health, who's been working with us, and Dr. Raul Cruz Cano, who is with the UMD School of Public Health as well, who has been helpful in participating in this analysis. And this underscores something that we had talked about before. We went out with effort and the plan of formalizing a partnership with the University of Maryland, their School of Public Health. I'm pleased to say I think the ink may not have dried yet, or is in the process of being put into place, finalizing the MOU with them to begin formally working with them across a slew of different projects. And this is a first effort that we've worked with their faculty and engaged their graduate students in terms of formalizing that agreement. And again, just another thank you to you all as a subcommittee again for creating the space and opportunity to move these efforts forward and have these types of conversations within the county. So data approaches, and we're happy to say that we have been doing a lot of work to educate folk in the community about how to use data, and one of those efforts was funded by Robert Wood Johnson this year, the -Kickstart grant that selected 5 jurisdictions throughout the nation to provide funding to do education in the community on why data is important, how it should be utilized, particularly as it applies to public health interventions. We were one of the 5 recipients, and 2 of our staff members, Rita Dang and Dr. Liu, presented at the national conference in Denver earlier this month and received praise for the efforts that we're doing to educate our community. We had the first data engagement session in early September. We had over 150 representatives throughout the community, different agencies, both intergovernment as well as non-government, who participated. And the next session is scheduled for Saturday, October 20th. If you all are free, we'd love to have you participate. And the goal is, again, to bring together different cohorts within the county to see what the needs are and what data folk are collecting, and to have some conversations about how we can operationalize data and use that to address the issues within our community. Now, the staff, they've probably laughed at me a lot in the last 6 months because I've been preaching data, and I finally have a name for the approach that we're taking. We've talked about it anecdotally, but we want to formalize that. And the approach that we're taking is called D2P, Data to Prevention, Promotion, Policy, Practice, and Planning. And what's significant about this is we formalize our efforts to use data more strategically and innovatively is that, as we launch this next effort, there are obviously staffing needs with that. As you know, our EPI program has 3 folks. And so we are relying on a lot of these partnerships and leveraging those resources in terms of graduate student expertise to help with that. But as we hope to grow the data-driven enterprise, not only within public health services, but also other areas within HHS to leverage data being used for public health purposes, we need bodies. So I'll just leave that right there as we think of that as we continue to move forward. So the first P, prevention. Some of the efforts that we've already launched in terms of data-driven for this purpose. We did release the annual health report earlier this year that highlighted health outcomes overall by disease. We utilize a set of novel strategies from geospatial hotspot analysis to census tract analysis in some cases, and try to streamline all of the different data sources we had to present that report. And that was the report that I presented heavily from in the presentation in July. It also highlighted areas and pockets of need and began continued the conversation about disparities within the community. And the goal is to, again, use that geographic specific information to help organizations, whether that's us, other entities within HHS, or other agencies within the Montgomery County, to be able to use that information to target interventions to those specific pockets in need. And one example of that is the sexual health data that we released in early August. as you all know, that drove a significant conversation in the community about sexual health and raised some alarms, and served as a basis for a larger conversation in terms of how we leverage our resources, particularly for young folk who we know that are disproportionately impacted by sexually transmitted infections in the county. I think I went too fast here. So promotion is the next one. So we were fortunate to receive some funding from the state around Babies Born Healthy. Again, it's important that this is the first time, at least I think in quite some time, that we've received funding around maternal and infant health from the state, because historically the state has not viewed Montgomery County as a high-risk, high-need area around that issue. What we have done is we have created a model and are working to create an algorithm that allows us to predict mothers who are at highest need, who may not be immediately identified based upon the resources that we have. And we are targeting a couple of zip codes that have, based upon the data, shown that they are historically high risk and high need. And the goal is to be able to coordinate, identify those women who may have historically not been seen as high risk, but to also look at other data points. For example, we know in our county we don't have a lot of deaths due to pregnancy, so our maternal mortality is not high in comparison to other jurisdictions that have received a lot of attention across the country. But our preliminary analysis, which we will be releasing, or the formal analysis releasing in the near future, showed that while we don't have a high number of maternal deaths, we do have significant maternal morbidity in the county. For example, African American women are 40 times more likely than their peers to have a complicated pregnancy and potentially a low birth weight delivery, and Latino women are 20 times more likely than their peers within the county to have a complicated delivery and experience some type of maternal morbidity related conditions. So the next component, the next P, is policy. Again, the purpose of this is to use the data to inform what grants we apply for, telling a different story, so whether it's the state or other entities, to reveal that we do have pockets of need in the county. And even though our overall outcomes may perform better than other jurisdictions, and our overall income and those types of measures may perform better than other averages, we do have need. And we need to figure out how we tell that story and also tie in data measures that shape how we perform, both in terms of those grant opportunities, but then also flipping that internally to look at how we improve our product. We know that as resources become tighter due to budget realities, we have to demonstrate our return on investment better, and we want to be able to implement data-driven metrics that show how we're doing and identify areas where we can improve so that we improve the product that we are putting out and delivering to the community. The fourth P is practice. Again, looking at how we can improve our performance in terms of quality improvement and performance measures. All of the subdivisions in public health services have been working this summer to identify metrics that are tied to the work that they do, particularly if they relate to grant expectations that we have from the state or other areas, to again make it easier for us to understand what the return on investment is from the funds that we have, and are we putting them in the right place? Are we performing in the best way that we can? And identifying areas where we may be underperforming, how do we fix that and how do we improve that with the resources that we have? Because again, we want to make sure before we come back to you all saying we need more money to fund this or we need extra staff and things like that, that we've done everything that we can to maximize our potential and maximize that return on investment. And so again, a couple of examples with how that shapes practice, again, using the sexual health data, that drove a conversation, and individuals like yourselves were able to use that data to advocate and make larger change, which I'm excited has been able to happen, particularly in areas that are sensitive politically, and where there are areas that are creating change that's not been there before. And in addition, one of the other efforts that we are hoping to move forward within the Healthy Montgomery piece is the Health in All Policies approach. And we're hoping that the data that we're putting out will bring folk to the table to help people understand how all of the different areas of life, transportation, housing, education, so on and so forth, contribute to having a successful outcome for each of the residents of the county. And so the hope is that after this report and several others come through, is that at the beginning of the year, we'll be able to convene the department heads or senior leaders within each of the different departments to have a conversation about how the data is showing all of these other areas influencing health outcomes, and how can we leverage that to change and advocate and shape policy to address what we need. And the last P is the planning piece. I've elaborated a little bit on this already, but using the data to help us understand where resources need to be allocated, where they will have the greatest impact, and also be able to demonstrate the return on investment of the programs that we're doing. It will also help us set our budget priorities. Again, hopefully this won't be the case this year or the year after, but recognizing that there may be budget realities that we have to perform within. And again, the health in all policies is an example of how the data will help with planning or influence that. So to give a couple of examples of data reports that we've already put out, we've spent a good amount of time talking about the status of health report that was released earlier this year. The plan is to continue this on an annual basis and hopefully demonstrate improvement in each of the areas. And one that is coming out within, it's in its final stages, is from that original report, the annual health report, we noticed that there were some problem areas that jumped out. One was infectious diseases. We've released the data around sexual health, and we'll continue to emphasize that and have that conversation within the community. But we also want to bring attention to other areas such as tuberculosis, where we actually do have higher rates, incidence rates, than the state and the national average, to highlight a need within the community. And this is significant because, again, tying into the policy and planning piece, the funding to support TB programs has been cut significantly from the national level that has trickled down to the state and has impacted what we have received from the state. For example, this year our budget was cut over $130,000, which represented a 37% decrease in the funds from the state to support that, while at the same time we have received increased requirements for reporting of latent TB conditions as well. So stay tuned for a more detailed report that will highlight infectious diseases, particularly STIs and tuberculosis within Montgomery County, coming within the next several weeks. So the big one that we like to celebrate, again, is the Robert Wood Johnson Foundation's Healthy Counties Outcomes. This is a map of the state of Maryland, and the colors indicate where the counties fall in terms of their performance. So the lighter shades correlate to the top 6 counties. Again, excited to say that Montgomery County is the #1 county, followed by Howard County, Carroll County, and Frederick County. The measures that nimble fingers here. The measures, the factors that the Robert Wood Johnson Foundation uses to measure healthy counties are listed on the slide. They look at a combination of health outcomes defined as length of life and quality of life, and health factors and health behaviors, clinical care factors, socioeconomic factors, and physical environment factors. And they utilize a whole host of different resources and data sources to create these measures. Some of which are a little bit trickier to apply on a more local level to understand the nuances and differences in diversity within different jurisdictions. So based upon that, we know that even within a particular county, there's significant variation in health factors and outcomes, as we'll see within Montgomery County. And the challenge is most surveillance systems don't collect very specific localized data, for example, zip code level data, which is as close as you can get to on the ground. And so there were some researchers in Missouri who created a new algorithm to use some alternative data sources that were more accurate depictions of what were happening on the local level, or more specific measures, to create a new framework within which to measure county outcomes. And so the new modified algorithm is shown here. So similarly, it combines health outcomes and health factors to come up with the overall health rank. and we're going to go into detail about these specific measures within the county. So again, length of life, quality of life, health behaviors, clinical care, socioeconomic factors, and physical environment. It's important to note that some of these measures are different. Again, they're more approximations that are more specific to the local jurisdictions. So for example, when you look at length of life is the same, but when you look at health behaviors, for example, the modified algorithm, it's just looking at sexually transmitted infections and teen birth weight as opposed to some of the measures for diet, exercise, alcohol, and drug use. And the reason for this is it allows for more specific local data to be used, particularly collected data from birth records, death records, the PRISM system that looks at infectious diseases within the state of Maryland. It's the state surveillance system and several others. And we applied this modified algorithm to the county, and as a good approximator for the statistics folks in the crowd, the Pearson correlation coefficient for this model was 0.983. So the closer you are to 1, the better in terms of the model being able to approximate the outcomes in comparison to the Robert Wood Johnson measures. And again, this is the reference point, the paper that was used as the source of reference for the model that was constructed. So without further ado, let's look at how we perform within the county. And one thing I also want to emphasize is that the maps that were provided in the health status report correlate to this. So you can think of when you're looking at the maps that look at cancer rates, diabetes, and things like that, you can line them up next to these outcomes to see where the pockets that aren't performing great on length of life and quality of life correspond, or increased hospitalization rates correspond to the areas where we know that there's significant burden of disease across the chronic disease spectrum. So the first measure is looking at length of life. The two components that were included in our model were age-adjusted mortality, basically what's the death rate, again, approximating across the board, and years of productive life lost. And years of productive life lost being defined as the amount of years based upon premature deaths in community. And premature death is defined as anyone who dies before 75. Your years per life lost are basically 75 minus whatever year you died. So that's an approximation of that. In the countywide rankings in Maryland, we ranked number 2. Our county average for length of life was 3,500, and the state average was 6,400. So overall, we did very well in this category. Now, when you break it down by jurisdiction and zip code, again, there are 42 zip codes within the county. When you're looking at this, so the maps break down the zip code, they have a color and a number. So the number represents where you rank in terms of the county, so 1 through 42, and the color represents which quartile that you rank in. So for this map, we're looking at the blue zip codes are performing the best, followed by the green zip codes, the orange zip codes, and then the red zip codes. So the red zip codes represent the areas where we have the worst outcomes in terms of age-adjusted mortality. And this is looking at deaths under 75 years of age. So similarly, if you flip it, if you did a life expectancy model of this, you would see the highest life expectancy numbers in the blue areas, followed by the green, followed by the orange, and followed by the red. And as a point of comparison, we have been looking at how we stack up against the rest of the DMV area. If you do an overall average, we look great. Our life expectancy is over 80, which I think is leading for the area, especially against our peers in Maryland, Prince George's County in particular. Our life expectancy overall is significantly better, but then when you break it down within the county, we see that there are numerous areas that actually are not doing so well in that measure. Sorry, my fingers are too strong here. The next is looking at years of productive life lost. Again, the blue areas represent the best performers, meaning they have the least amount of YPLs, or years for productive life lost, followed by green, followed by orange and red. And then when we put those factors together, looking at overall length of life as a measure, this is how the county stacks up. So again, the blue zip codes are the best performers, followed by green, followed by orange, and followed by red. And when we break out and pull out the top five zip codes in county for length of life are the Glen Echo community, Washington Grove, Ashton, Bethesda, and Brinklow. And the bottom five zip codes are Silver Spring, 20910, Spencerville, Colesville, Sandy Spring, and Poolsville. So our next measure is looking at quality of life. The components measured in this are inpatient and ER hospitalization rates, mental health related hospitalization rates, and low birth weight deliveries. And again, it's important to highlight that we, in the state of Maryland, we are number 2 in comparison to the other counties and jurisdictions. When we break that down further, we look at the hospitalizations per 100,000 people, the rates within the community. The county average is 29,851 hospitalizations per 100,000 folks. And again, the blue areas have the least amount of hospitalizations compared to the green, then the orange, and then the red areas. When we look at the percent of live births with low birth weight outcomes, low birth weight is defined as an infant that is born is less than 2,500 grams or 5 pounds 8 ounces. The county average is 7.3%. And again, when you look at the quartile analysis, the blue areas actually are the better performing areas. They have the lowest percentage of low birth weight deliveries. And again, keeping in mind 7.33 is the overall average. And so you're looking at the green areas next, which are 5.7 to 6.7. The orange areas are 6.8 and 7.7, which would include most comparable to the county average of 7.3. And then the red areas have percentages over 7.8 and as high as 27.8. The third measure is hospitalizations for mental health conditions. Again, we know that in this county, behavioral health is a significant issue. And actually in the state of Maryland, particularly when we look at the disparity in terms of the number of inpatient beds that are available for individuals with behavioral health needs and conditions. Again, the county average is 1,774 hospitalizations per 100,000 people. Again, when you look at the overall numbers, the blue numbers perform best. All of those zip codes are below the county average, followed by the green areas, which are also below the county average. Next, the orange, and then the red zip codes. Putting those all together for the quality of life measure, which puts all of these three components into one, we see that here is, if you look at quality of life based upon those, here's how it stacks up in the county. So again, the blue zip codes perform best, followed by the green, the orange, and the red. And I missed one. So pulling out again the top five and the bottom five for quality of life, I do want to note that there's one error. I'd like to take out Spencerville. We found an issue, one concern with the data that we'll follow up on, but Chevy Chase would be fourth in terms of the top five quality of life zip codes within the county. And Glen Echo, number 1, Bethesda, Cabin John, and Chevy Chase. And then the bottom five zip codes, based upon the measures, are Montgomery Village, Darnestown, Poolsville, Ashton, and Brinklow. The next measure is health behaviors. For the purpose of this algorithm, the two components were sexually transmitted infections and teen birth rates. And in the state of Maryland, based upon the Robert O. Johnson rankings, we finished number 1. As one measure, looking at STIs overall, I won't go into much detail, but we have had significant conversations in the county recently over chlamydia, gonorrhea, and syphilis rates. We know that the chlamydia rate, the increase in new cases was approximately 30%, which was double the state average of 15%, and the increase in gonorrhea cases was approximately 15%, which was double the state average increase of 7.9%. So when we look at STIs overall, you can see the rates. The blue zip codes are performing better than, again, for example, looking at chlamydia infections, the average was 271 infections per 100,000 people. And then when you break that down by the county, the blue areas are in the top quartile, followed by green. And then both of those sets of folks are performing than the county average, and then followed by the orange areas and the red areas. When we look at birth rate for teen mothers, the county average is 11.8 births per 1,000 teenage females. And there are a couple of areas that are white, just to emphasize that there were very low numbers for those zip codes. So from a statistical standpoint, we're not reliable measures, so we're not included. But when you look at the birth rate, the teenage birth rates across the county, again, the blue areas are the highest performing, followed by green, followed by orange, which that group includes the county average of 11.8, and then followed by the red zip codes. And when you collectively put them together for health behaviors and looking across the county, the blue areas are the highest performing areas, followed by green, orange, and red. And when you pull those out, the top 5 zip codes in terms of performance for health behaviors are Garrett Park, Cabin John, Bethesda, West Bethesda, and the Dickerson 20842 zip code. And the bottom 5 zip codes are the Wheaton Silver Spring 20902 zip code, Aspen Hill, Gaithersburg, Silver Spring again at the 903 zip code, and Montgomery Village. Moving forward, looking at clinical care factors. The clinical care factors, the components for that measure, were the percent of population employed in healthcare. And this is a little bit of a tricky measure because it does not measure, it measures where the healthcare providers live as opposed to where they are located in terms of providing those services. So the 2 other measures that are better approximators of clinical care factors are after-hours emergency department visits and hospitalizations for preventable conditions. And on the state level for the Robert O. Johnson measures, we rank number 2. When we look at after-hours hospital visits per 100,000 people, the county measure is 2,400 after-hours hospital admissions per 100,000 residents. And you see how each of the different zip codes stack up against that. I don't have to tell you what the color scheme matches, but it's important to note that, again, the second quartile includes the county average of 2,406. So you can get a sense of how people are performing. Next is the percentage of population employed in the healthcare profession. Again, this is a little bit trickier because it shows where the folks live as opposed to where they actually work. But you can see where the highest percentage of healthcare professionals live within the county based upon the percentages. Or actually, in this situation, the blue number actually is best. So the higher percentage you have, so the areas that are blue have higher percentages of their population employed in the healthcare profession. So in this case, the red would be the worst color, followed by orange, green, and then blue. And the third measure is looking at hospitalizations for preventable conditions per 100,000 folks. The county average is 675 hospitalizations for preventable conditions per 100,000 people. And this gets to the heart of the chronic disease and primary care management, because we know a lot of these preventable conditions could be things that could be followed more closely by primary care providers, as well as harbingers of chronic disease that may not be managed carefully and managed well. And so this is a measure that approximates all of those particular instances. Again, in this situation, the blue zip codes are the better performers, followed by green, orange, and red. And when you put them all together, the clinical care factors, this is how the county stacks up. The blue areas are the better performing compared to green, orange, and red. and pulling out the top 5 and the bottom 5. The top 5 are Glen Echo, Bethesda, Cabin John, Chevy Chase, and Washington Grove. And the bottom 5 zip codes for clinical care factors are Ashton, Burtonsville, Colesville, Sandy Spring, and Brinklow. Next, we have socioeconomic factors. The components that were used to measure this in the algorithm were the population with less than a high school education, unemployment rate, childhood poverty rate, and median household income. And collectively with these and the measures within the Robert Wood Johnson County rankings, Montgomery County finishes number 4 in the state. When we look specifically within the county, for example, we look at the percentage of children under 18 living in poverty. The county average is 8.53%. And when we look at the chart, the blue and green quartiles are below that. And the 8.53 average is captured within the 3rd quartile. So blue again having the lowest percentage of children under 18 living in poverty, followed by green, orange, and red. When we look at the percentage of population with less than a high school diploma, the county average is 8.79% of adults over 25 who have less than high school diploma. And that average is included in that 3rd quartile. The blue quartiles are 0 to 2%. Green is 2 to 4.9%. The 3rd quartile is 5 to 10%. And the red quartile, which is the 4th quartile, is 10% or greater. And the highest percentage, there's a zip code that has a ranking of 35.9%. We look at median household income. The county median income is approximately $99,500. The range of incomes for Montgomery County median incomes ranges from $58,946, which is the median income of zip code 20903, to a high of $195,114, which is the median income of zip code 20854. So when you look at the chart here, it's flipped this time. The highest numbers are the blue jurisdictions, which have the range of 145 to 195, and the red areas show the lower median household incomes. When we look at unemployment rate, again, as another measure of socioeconomic factors, the county unemployment rate, looking at it from a rate of per 100,000 people, is 6.07. And civilians who are 18 or older who are unemployed per 100,000 residents in the civilian labor force. The blue zip codes indicate the best performing, they have the lowest rates of unemployment per 100,000 persons compared to green, orange, and red. And then when you put these together, looking at the overall county, the blue areas perform best in terms of socioeconomic factors, followed by the green zip codes, orange and red. And then when we highlight those top 5 and the bottom 5, I don't think it's a surprise to most. The top 5 zip codes in terms of socioeconomic factors are Potomac, Ashton, Glen Echo, Bethesda, and West Bethesda. And yeah, shocking, I know, right? And I want to highlight this because this, as someone coming into Montgomery County from another jurisdiction and then hearing other people talk about Montgomery County, this is what they assume all of Montgomery County is like. Everybody's in the top 5. And we know that that's not the case. And so again, this underscores why the data is important to tell that different story. And then we see the bottom 5 zip codes, the Rockville Twin Brook area, Wheaton Silver Spring, Aspen Hill, Montgomery Village, and then the 903 zip code in Silver Spring. So the last measure is looking at physical environment, and this is actually the area where we scored worse in the Robert Wood Johnson rankings, county rankings. Their physical environment rankings include air quality, a host of things, and what's different about this is we're looking at violent crime rate and injury death rate. So the new model algorithm this is probably the one that's the biggest difference, is looking at the physical environment being defined as preventable mortality. So injury prevention, violence prevention as better harbingers and easier to measure metrics in terms of what the physical environment looks like. Unfortunately, I will say this from the health perspective, we do very well in terms of our water quality and our air quality in comparison to other jurisdictions. So I want to keep that in mind as we take a deeper dive in the physical environment measures. So the age-adjusted mortality due to injuries, the county average is 34.8 deaths per 100,000 persons due to injury. And again, in this area, the blue areas have the lowest number of deaths related to injury compared to the green, compared to the orange, and then compared to the red areas. And then when we look at hospitalizations due to violent injury, that's either to firearms, assault, rapes, etc. The county average is 157 hospitalizations per 100,000 visits, 100,000 persons. When we look at the numbers here, again, the blue numbers are the best, and the county average is captured within the second quartile, which is 97 to 163. We put all of those together for our overall number. Again, the blue quartiles are the best performing, followed by green, orange, then red. And then when we pull out the top 5 and the bottom 5, the top 5 zip codes for physical environment performance are Glen Echo, Washington Grove, Ashton, Sandy Spring, and Bethesda. And the bottom 5 are Aspen Hill, Brookville, Spencerville, Brinklow, and Poolsville. So how do we put all this together? What does all this mean? What does this look like collectively? So similarly to how the RWJ brings together their county health rankings, we factor in combining each of these different subdomains. So when we look at health factor, the health factors, which we looked at health behaviors, clinical care, socioeconomic factors, and physical environment, when you combine all of those together, here's how the county stacks up. The blue zip codes are in the top quartile, followed by the green, followed by the orange, and then the red zip codes. And when we break those down by top 5 and the bottom 5, looking at health factors, the top 5 zip codes are Ashton, Glen Echo, Potomac, Bethesda, and West Bethesda. We heard that a little bit ago, didn't we? In terms of outcome, is that an interesting coincidence? And then we look at the bottom 5 zip codes: Rockville, Twinbrook, Wheaton, Silver Spring, Aspen Hill, Montgomery Village, and Silver Spring, the 20903 zip code. And the last slide I want to show you, or last 2 slides I want to show you, is putting it all together for the overall rank. So combining health factor scores and health outcomes, what does it look like in this county? Which zip codes are the healthiest in comparison to others? When you combine all 6 domains, length of life, quality of life, health behaviors, clinical care, socioeconomic factors, and physical environments, the blue zip codes are our top performers. And followed by the green, the red, orange, and the red. And then when we pull out those top 5, again, we see that Glen Echo, Potomac, Bethesda, Ashton, and Washington Grove, followed by, or the bottom 5, Rockville, Twinbrook, Wheaton, Silver Spring, Aspen Hill, Montgomery Village, and the 20903 zip code of Silver Spring.
Great. Okay. Well, I have a lot of questions. What I'm going to do is I'm going to ask a question, and you can answer it, and then I'll yield to Mr. Rice, and he can ask a question, and you can answer it. Then it'll be my turn. We'll just go back and forth. No, I'm quite serious.
Can I have like a couple questions within a question? No, I'm just kidding.
No, I'm quite serious. I think we're going to, each of us have been taking notes, and each of us are going to have a lot of questions, and I am not going to utilize my prerogative as the chair to monopolize the microphone. We're going to go back and forth, okay? So my first big question is that if I'm understanding this correctly, what you've tried to do, so I brag all the time about the America's Health Rankings compiled by Robert Wood Johnson Foundation. And I understand that what you've tried to do is do sort of a micro-modeling exercise based not precisely, but fundamentally on those data indicators that exercise America's Health Rankings utilizes. Is that correct?
Yes.
Okay. Okay, I'll yield.
Oh, that was.
Yeah, no, let's go back and forth. I think it's fair.
So,
And
Dr.
Can I just
no, please.
add to that? Because what we felt it was important, again, to not just leave it as, yay, we're number one again in the health rankings, and we'll wait to see what happens next year in the health rankings. Because we want to tell that different story to say, yes, collectively overall, our outcomes are great, but we need to start having a conversation about those areas within the community where we know anecdotally from the work that we do that everyone's not having that great of a health outcome, to try to understand, all right, how do we then leverage our resources and be more proactive about addressing those areas to one hope. I mean, ideally, our ranking should improve if we pull everybody up in terms of the averages, but to take a proactive stance in terms of addressing those areas before they become, hopefully never reach crisis level situations, which would allow for us to, not having to operate from crisis mode, allow us to be more innovative and thoughtful and think outside the box to address those.
Okay, well, I'll ask a follow-up, and then you can have a question and follow-up. I like everything about this report. There are alternative approaches that you could have adopted, and you identify yourself the issue where just because health personnel live somewhere doesn't really tell you anything. I understand that the proliferation of health personnel in the population at large relates to access to care for the population at large. That if you don't have to travel a long distance to get care, and if when you get to the emergency room you don't have to wait all day because there's enough health personnel to look after your needs. So I do understand that. But the zip code approach seems potentially somewhat reductive. And that gets to other questions that I'll get to after Mr. Rice has his chance, where we need to coordinate with the efforts that are already underway. And I personally think that a demographic breakout rather than a geographic breakout is probably more instructive. I think probably Latino families in Gaithersburg have more in common with Latino families in Long Branch, and it doesn't really matter it doesn't matter quite as much what the zip code is as perhaps other characteristics like economics and like demographics. So this is, the data show what the data show, and you're going to get out of the computer what you punch into the computer. So this was the question you asked, and this is the answer. But it does speak to, is this the most efficient and effective way to target resources? Because, we're not going to have a Brinklow initiative, but we do have an African American health program.
And to that,
Oh, you're fine.
So I don't disagree. I agree completely. I think the purpose of this is to help drive that conversation. So when you identify these pockets, to say, all right, well, who's living there? So the purpose of this is to set the stage to supplement those ongoing conversations, to bring other folk in to say, all right, well, if we're saying this zip code have this issue and this zip code over here, who's living there? An easy answer may be, well, the same demographic group in terms of race and ethnicity may be living there. Okay, well, what's driving, what are the other factors that are driving these outcomes? And so the hope is to use this to start the conversation,
sure,
to bring, to, as you said, to do exactly what you're saying, is to study these communities deeper and figure out, is there a demographic issue here? Is it really a transportation issue? Is it really education? To figure out what that root cause is, to be able to link all of the different communities that have the outcomes and say, well, wait, this is the common factor of you living in Gaithersburg versus me in Silver Spring. And so maybe we need to figure out how we can leverage that and work together and figure out best practices and what we're already doing and enhance what we're doing to take it to a different level to address those concerns. So I think we're in total agreement.
Yeah, if you take zip code 20903, for example, which is a big blinking red light here, north of the Beltway it's pretty affluent, south of the Beltway it's very low income. So you could even get deeper into within that zip code, and it may not tell you all that much because the answer is it's the black folks and the immigrants in 20903 who are struggling. But I'll yield to Mr. Rice.
Well, let me just start with that, because that's the amen in this whole part of the process. Look, I grew up in 20906, so I see it at the very bottom of the list. That's where I was born and raised, and so I know, just as you said, the differences in the communities in 20906. You've got one side of Belpre, and you've got the other side of Belpre, right? And so there's no question that what anecdotally we know about these neighborhoods and these zip codes is helped and supported by the data. And that's what I'm really excited about. It's interesting because I think that I want to talk about your methodology and the whole D2P approach, because I think that it's something that we were trying to do with the Kerwin Commission when it came to really starting to follow the individuals instead of trying to look at this from a district-wide or a county-wide perspective, understanding that there is such disparity, not only within the zip codes themselves, but then even lower below the zip codes when it comes to neighborhoods. And is the reason why we started saying that the money needs to follow the child. In the same instance, in this case, the money needs to follow the individual. And what we're seeing is, and we're starting to identify via what you've broken down, we can then go into these zip codes, and I can already tell you who they are and where they are. We already know, and our minority health initiatives do too. What this has done for me is justified that we need to put more investment, because I know who the people are, right? Rockville, Twinbrook. I can tell you right now, that's our Latino population, our immigrant population. Wheaton, Silver Spring, Latino immigrant. Aspen Hill, African American, some Latino coming in and sprinkling in that area. Montgomery Village, heavy Latino, heavy immigrant population. Silver Spring, mishmash of immigrant, Latino, African American. I mean, we already know, and they're all represented. And then a lot of our lower income Asian folks are in some of those areas as well, sprinkled in. So it's like, I'm very happy, Mr. Chair, and thank you for having the minority health initiatives here, because it's a true part of our conversation about what it is that we're going to do, just as we had with Kerwin. It's going to be a renewed investment in those minority health initiatives to get at some of these problems that we're seeing, right? Because whether it's with STIs, whether it's with tuberculosis, whether it's with infant mortality, whether it's with premature death, right? And the programs that we can do for interventions, it's all for all of these communities, right? That's where the higher incidents are. So, Mr. Chair, I agree with you that it's good to see what the demographics are, but we honestly already know. We already know what they're going to be. It's people who are in this room who are representing those folks. So that's my one statement. But the question along those lines is you talked about result-oriented practices and what we need to do regarding how to ensure that staffing follows that model. Is it your intent that based on these numbers, there will be recommendations for additional support, not only for our minority health initiatives, but also within HHS to help to address some of these glaring disparities that we're seeing throughout the county?
Well, I think it's a global perspective in terms of, again, providing the data to help drive the conversation. And at least coming from my desk, less about saying, here are the definitive answers, you need to fund this person for 3 positions in that position. However, providing the support to be able to have those conversations. So again, going back to, we preach on our staff, it's before we come to you and ask you for things, we want to be able to demonstrate, all right, have we done all of our due diligence to maximize and get our house together right? And have measures to show that, to say, all right, we have implemented quality standards. It's the expectation if a client calls our ACCU DACT program and needs to get linked to services, the expectation should be that everyone should get that call and close it within a certain amount of days. Because we know we need to do that. We own that. And so being able to go in and say, all right, we can ensure to you when we come to you and say, 95% of our clients who call for this service are linked with an appropriate amount of time. So then the next ask is to say, all right, well, we're experiencing significant shortfall in that area. The caseload is significant. And before I ask and say, hey, we need more people, we want to be able to demonstrate, here's what we've done and here's what the data shows. And then on the other side of things, the data shows where there's significant need in the county is, and it underscores why we need to potentially prop up and have more services in that area. So I think from a global perspective, the purpose is to help provide the data to drive those conversations wherever they need to be had. But certainly the expectation would be in some of these needs, it would help solidify our asks to show, for example, I know Becky Smith is behind me, for the maternal health piece in Babies Born Healthy. One of the goals is we wanted to look at how we could elevate that to a county level priority in terms of a position. And so, there wasn't a pin necessarily there, but because again, historically, the state has not viewed us as having a high risk in that area. But that's different now that we were able to be determined to be eligible for that grant. We're looking at the data to drive that conversation to say, all right, let's identify where these women are, get them linked to all of the great services that are in place already. I'm thinking of Project Smile from AHP, so on and so forth. But what's the next step? What are our needs? What's the workforce piece of that? What's the outreach piece of that? Is this a question of we need more bodies to do the work? Is it we need to launch a PR and ad campaign to raise awareness about it? So again, collectively, the purpose is to put the data out there to help inform all of those different conversations in terms of getting the needs met.
Just do a quick follow-up. So along those lines, Dr. Gales, and I will say that we don't have a county executive budget before us right now, so there's nothing to either defend or say, we're impinging upon. So what I want us to do is be bold and innovative, what I've been challenged to do on the Kerwin Commission. So from that perspective, I think you've given us the data, and it's very clear that, again, just as we see within all the other hotspots, and I can tell you the same areas that you've identified when it comes to adverse health outcomes, I've identified the same areas when it comes to adverse education outcomes. No surprise, right? And so from that perspective, I think that it's important for us to be aggressive in really starting to push forth and say, look, now that we have this great information, and I agree with what the chair opened with, this is incredible. You have taken reports to a whole nother level in terms of how we can have more data-driven, data-informed decisions that are very strategic and very focused, right? Instead of us just saying, well, we know that we have a issue of STIs in the county, so let's just spend some money. No, we know exactly where the problems are and where we can focus our efforts. So from that perspective, and your position as public health officer, would you not agree that it would be smart for us to follow the data that you've given us and strategically invest in making sure that in partnership with our minority health initiatives and other kinds of programs within HHS, we can address these issues you've identified?
I would agree an infinite percent on that.
Thank you.
Well, I just want to issue a caution, though. It gets to my next question. What's interesting to me here, there are some anomalous results for any one indicator. And again and again and again, the sparsely populated parts of the county are ranking in the red. And yet, Poolesville and Seneca are not economically stressed areas. And I'm sort of, well, that's the question.
HOC then. That's driving that. That's what's driving that. HOC in Poolesville.
Okay, well, I'm sort of surprised. Poolesville, I find that surprising that on indicator after indicator after indicator, when you get out in the country, and Poolesville in particular, is in their Dickerson, Monocacy. These are rural and wealthy areas. And does the sparseness of population somehow skew the way the indicators come out? If there's just fewer people in a particular area, then does a relatively small incidence of a particular condition trigger that whole area into the red?
Well, two things. First, to just finish a last point for Councilmember Rice's point is we're able to do this because we have a strong team. Dr. Liu and his team are fantastic in terms of he probably more so than anyone on public health service staff experiences an idea come in and he can make it happen really quickly. And again, he has a great team working with him. And I'm excited to expand the partnership.
Dr. Liu, identifying to it? Yeah, okay.
And expand our partnerships with...
So he's your epidemiologist?
Yes,
Yeah.
he is our epidemiologist. And expand our partnerships with the academic partners within the community. But again, emphasizing that we have a staff of 2 to 3 folks and an epi team. And that, I think, gets to the question of, ask in terms of being bold. if we want to continue to move forward and be as innovative and cutting edge, particularly as it relates to data, whether it's surveillance or epidemiologic data, there needs to be, more of an investment in that area and support. So to your specific question, certainly numbers can influence the statistical outcomes. And I would say, had I not spent some time in the Poolesville area this summer, meeting with them to talk about their needs, particularly around social services needs, I would be more inclined to say, well, yeah, it could just be an anomaly related to, the numbers in population. However, as it relates to Poolesville, and I hope they're watching, as we haven't forgotten about them. We've been working with to understand their needs. So they approached us and said, hey, we are a little bit of a social services desert here. In terms of having healthcare providers, I think they have 2 primary care physicians, one of which does not accept Medicaid, I believe. Forgive me if that's wrong, but again, just 2 doctors for a small community. And one of the anecdotes that they provided, I asked them to provide some data to better understand. Recently, they said if you are trying to access county services, and you don't have a car, you've got to get up get on a bus at around 7, get downtown, get on a bus, because the buses don't run all the time. They only run in the morning, and then there's a period where they don't, and then they're in the evening. Get on the bus, drive. It takes about, I guess, due to the bus routes and connections, it will take you about an hour and 20 minutes to get to, I think they were using Germantown as a point of reference, to get the services, and then hypothetically, you would be done getting your services at, say, 11 o'clock, but the bus back to Poolesville doesn't start again until after 2. So you're waiting around during that time period. So while I do think there could be some influence due to the lower population, I do think it's important to, again, this underscores why I think it's important to do that deeper dive after this analysis to understand what are the community factors that may be driving those outcomes, as opposed to just saying, well, it's probably an anomaly, there's really no need there. So I think it could be a little bit of both, but I don't want to get lost in that, even though they may be performing well in terms of economic indicators, there still may be some needs there in the community.
There may be. Right. I mean, I agree you want to delve into it and
Sure.
figure out what's the answer. That was the purpose of my question. Similarly, you look at some of these anomalies, there is almost no difference between Ashton and Spencerville in terms of they're right next to each other. The demographics are the same. They're geographically located quite close to each other, and yet Ashton's kind of all over the place. Sometimes it's high, sometimes it's low. So some of these, it doesn't always fit with the predisposition. You would assume that, deep inside the Beltway on the Prince George's County border and in areas of Gaithersburg and in Montgomery Village, that you would have, more of the red zones and more economically stressed families, because we know those things to be true. But in some of the other areas of the county that end up ranking similar to those areas which we know are the lower income areas, it just raises the question, why that? I mean, it makes you scratch your head. I mean, for example, hospitalizations for mental health conditions per 100,000 people. So you have an area around Barnesville where there were not any statistically significant amounts of those hospitalizations, right in the middle of a heavily red zone of Dickerson and Poolesville. Well, there's no way to explain that. I mean, they're the same. What's the difference between Dickerson and Barnesville? So in the rural areas, I think you're dealing with such a small population base that even a minor fluctuation in incidence will cause all kinds of outsized differences in the relationship between the numerator and the denominator.
That's entirely possible. Sure.
So I have a lot of questions, but it's your turn.
So to that end, I think that while we will have to work through some of those anomalies that are out there and delve in deeper in terms of what the numbers truly mean. In some cases, they are significant. In other cases, it may be anomalies, just like the chair had mentioned. But I want to tie into my district that I know near and dear, which encompasses Germantown, Montgomery Village, Boyd's, Hyattstown, Dickerson, the Up-County, and part of Mid-County region, in which typically falls in the lower quartile. They may not always fall in that top or low bottom 5, but they're in the bottom 10 to 15 throughout the county consistently amongst all of the different rankings. And so my question is this. It's very interesting in terms of where Germantown, that has a hospital, has an emergency facility, has tons of private providers that are there providing a myriad of services. You know, we've got medical parks up the wazoo, all kinds of things like that, but still are challenged with health outcomes. And so I know that that was part of one of the methodologies there that dealt with medical professionals, access to medical care, things along those lines, but we still have, I mean, when you look at our overall rankings, I mean, so let's just go to the very end of your slide. Montgomery Village is 41, and I think Germantown in overall rank was probably somewhere around it's 34 out of 42, so pretty much still close to the bottom, especially having the amount of healthcare that you do. What do you attribute something like that to where you've got access to a lot of the things that should be providing positive health outcomes? You've got neighborhoods that sometimes Germantown actually scored when it came to some of the quality of life issues. Some of them are red, but some of them are in yellow and green in some cases. What do you attribute that to?
Well, I think you're right. There are some areas within our county that do have significant resources. I mean, again, that's the rub on Montgomery County. It's the land of infinite resources. But I think it underscores that just because they're there doesn't mean folks are actually accessing them and utilizing them. And I think it begs a deeper conversation to understand that even when they are in place, one, looking at utilization rate. So even if you've got them there, how many people are walking through the door? How many people are actually utilizing the services? For those who are utilizing the services, how are they utilizing the services? And are they savvy enough to be able to navigate the system to get the resources that they need? And then the third component is for those who are successfully navigating the system, what have been the best practices in terms of engaging them and getting them within the door? And so I think looking across that continuum, I think there is an opportunity to better understand for those that are locked out of the system, even if it's right next door to me, what's keeping me from being able to make that connection and that loop. And for those who have kind of gotten into the system, are we looking at a question of, is it a health literacy question? Is it a, insurance affordability question? Are there other fears that may be preventing folks from getting there? So again, I think it begs to have that conversation to say, even if they're there, the resources are there, what's preventing folks from being able to get in and access those resources? Because I do think, from the public health perspective, and I'll take responsibility for this for being a public health official, we do suffer sometimes from saying, all right, well, here are the resources, why aren't you coming to use them? So how can we better repurpose ourselves to do more engagement, to make sure it's a welcoming environment, that folks know about the resources that are available, make sure that they are open at a time that is convenient for folks. So for example, not to keep talking about sexual health, but one of the components of our sexual health program is it's really difficult to get STI screening after hours in the county. Unless you go to an emergency room or an urgent care facility, there aren't a lot of venues where you can pop in, particularly for young folk, after school, or they can go and get a screen. In DC, there's a lot of, different venues, clinics, and youth spaces, for example, where you can pop in, it's 8 o'clock, they're doing drop-in testing at location X every Tuesday, Thursday, that kind of thing. We don't have a lot of those places within the county to do that. So even if I've got great insurance or I can pay out of pocket, it's just hard for me to get to unless I drive to another jurisdiction. And so, putting a magnifying glass to highlight what those particular barriers of entry may be. Now, conversely, and we fortunately partner with the hospitals, and they're great partners in terms of a lot of different programs from the public health perspective and service delivery. It's continuing to look at better ways to leverage those resources and be more outward facing in terms of educating the community about the resources that they have available, and helping people understand how to navigate and get into their systems. We recognize that, and for example, one of the projects that we are working on doing, we don't have exact dates yet, but stay tuned, is within Healthy Montgomery, because actually that was an issue brought up with Healthy Montgomery, that a lot of people heard about it but didn't really know what we were doing. And so we wanted to figure out a way to engage the community, so we created this notion of community grand rounds that would give folk an opportunity to us to highlight what we do or what services we provide for a particular health condition, to bring in experts who live within the county to be able to talk to the community, and then give the community an opportunity to interface with those experts, interface with HHS staff, to be able to have conversations about, so you have this beautiful facility, you do all this top-notch stuff, but how do I get to be a part of that? I didn't even know it was there, and how do I get in? And one of the things that we're doing is we've asked each of the hospital partners in Healthy Montgomery to take the lead on those and to host one of those events. So again, that gives an opportunity to bring in the community to see the spaces, hear about what resources are available, and figure out new ways to engage and interact.
Can I just follow very, very quickly? It's just, I would like to see, and I don't think I see this now, and we have the minority health initiatives, so they can either nod or just, Mr. Chair, however you want them to respond to this, but I'm not sure if the partnerships between our hospitals and our health entities are as strong as they could be with our minority health initiatives that are out there in the community, supposed to be outreaching to our community and then connecting them to these kinds of things. So maybe a strengthening of that with that support mechanism that's there between our health entities and our community organizations would be helpful to make sure that we're not only gaining that outreach and infiltrating into the community, but then also they're able to bring in those folks that you've talked about and get them aware of the services that are being provided. I couldn't agree with you more. I think that, again, look, it's the same thing, and I hate to keep equating it to schools, but it's the same sort of thing as we talk about academic programs, as we talk about, bless you, as we talk about resources that are available. I continue to hear the same thing. I didn't know that we had that. I didn't know that we had a George B. Thomas Saturday school that was basically for free, and I could send my kids there, and I thought I had to pay for a tutor. I mean, we call every day, right, before school on the weekend and talk about George B. Thomas and talk about what's available, but, you know, again, so I think that you're onto something with that outreach piece, and we need to beef up what it is that we do to make people aware, Mr. Chair.
Well, let me follow up on that. The big picture question: how does this statistical analysis cohere with the other related health efforts? This was my big, like, wow, when I first saw these slides back, you know, before the summer. Tonight, I assume you'll be there. I'm going to attend a presentation from the African American Health Program, and you know, they have been ringing the bell for a long time about a need for better data analysis. So here you have your statistical team, and you've produced this report. How are you coordinating this effort with the minority health initiatives? How is this effort coordinated with the Healthy Montgomery Steering Committee, which I serve on, and before which this presentation was never made, and which we produced, the Healthy Montgomery Steering Committee produced the Community Health Improvement Program, which didn't draw from these data. So as much as I really like this approach, and you know, again, I'm showering you with praise every chance I get, I am asking for a little more cohesiveness. We do seem to have somewhat atomized and disparate efforts striving towards the same goal, but not apparently as coordinated as they ought to be.
Sure. So that, I agree entirely, and you know, thank you for your support on that. And if you don't mind, I actually would like to share a comment, part of the discussion in our last Healthy Montgomery Screening Committee meeting where you brought this up.
Right.
And one of the things that you mentioned is who's setting the public health agenda.
Right.
How do we, you know, do that? And so that's been something that we've been working on throughout the year, is to try to streamline efforts, bring together folks. For example, one of the projects, and you know, unfortunately, things get busy, that has been sidetracked a little bit, is that we brought together, we convened the promotion and prevention folks from Public Health Services with the Healthy Montgomery staff, and then invited the minority health initiatives. And we were meeting monthly. We haven't had a meeting in a little bit. But to basically address that concern is to say, okay, well, there seems to be lots of efforts in equity, social justice, efforts tied to particular disease outcomes. And at a minimum, we should meet maybe at least once a month or once every other month to just say, hi, here's what we're doing, you know, to know what everybody else is doing, to figure out ways to partner and align our interests, or to be able to support each other. My hope is that by taking this data-driven approach is that it can create some global metrics or standards to help drive those conversations. So, for example, when looking at data for a particular health outcome, we can set and say, hey, you know, as a county, diabetes is a priority for us. You know, here are our county metrics that we think, you know, we've spent time thinking about in terms of here's what we deem to be healthy outcomes when looking at diabetes care within the county. And then being able to collect the data, to highlight those and share with all of the different entities, the minority health initiatives, the public health service programs, other entities within HHS and outside of that, to say, on a county level, here are our expectations, here are our metrics, and we can serve as a convener of all the different groups doing work in that area to help see what their technical assistance needs are, provide them with the data to help drive their efforts in terms of streamlining and targeting their interventions, and bring them together to be able to share best practices, strategically align when it comes to, you know, asking for budget resources or pursuing other grant opportunities. And I think that is a work in progress, but that's certainly the direction we're moving in, because I agree with you, there is a lot of duplication in the county, and, you know, we can do better in terms of putting together our resources and being one cohesive unit.
Well, that wasn't a really good answer. That's the answer coming from a place of a very well-funded county with the ability to tolerate, you know, multiple efforts and let 1,000 flowers bloom, and I don't think we are that county anymore. So I hope that now that we're in transition, look, I have the scars. I tried to eliminate some duplication in the proliferation of boards and commissions, and there was not one other council member who went along with me on that. So maybe Mr. Rice did, sort of. When push came to shove, though, it just died. The whole thing, the whole effort died.
Us.
Yeah. I think that, well, we'll see what is the presentation tonight, but, you know, African American Health Program has been coming to us year after year after year saying we need more data analysis capability, and you've got Dr. Liu and you've got help from Dr. Marcia or Ms. Marcia and Dr. Raul Cruz Cano. I mean, there are significant resources that were employed to produce this document, and if those resources exist, they may be able to answer some of the pressing questions that the minority health initiatives are raising, and I'll listen with great interest tonight to the AAHP data presentation. But, you know, I'll just put it out there. I think that having a Healthy Montgomery Steering Committee and a Commission on Health and an Alcohol and Other Drug Abuse Advisory Committee and a Mental Health Advisory Committee and a Montgomery Cares Advisory Board is more than even this big county needs. And some of those groups, and an African American Health Program Steering Committee, and an Asian American Health Initiative Steering Committee, and a Latino Health Initiative Steering Committee. So what are we up to now, 9? Okay, so, you know, honestly, as I go out the door, and I'm not running for office, and I'm not afraid of, you know, having anyone get mad at me because I'm suggesting there's anything other than indispensable, some of those committees could be subcommittees of a larger whole. We just have too many of these structures, and they don't, as you say, they don't know what each of the other is doing, and to say, well, maybe at a minimum we ought to get together once a month and find out what each is doing, that should have been happening a long time ago. So you can play a role there. I mean, something comes up, we're not able to respond to it quickly enough. You have, and this is, I'm repeating what I said at the Healthy Montgomery Steering Committee, but I'm on the record, and this is still my committee for a few more weeks. Well, and not even to mention the County Council's Health and Human Services Committee, which exists for a reason. I mean, you have an executive branch and a legislative branch, so, you wouldn't eliminate that. But at some point, we've got to look at making that more logical and utilizing the resources that we have system-wide to benefit every part of the system. And I don't think we're doing that. I don't think we're doing it. I don't think we're doing it in public health, Doctor.
Well, I don't disagree with you on that. I think part of the challenge is, at least from my perspective, being a new person coming into, historical precedent in terms of these relationships, is being very mindful and thoughtful on the best ways to approach that and do that. And I think that, a year isn't tenure by any stretch of the imagination.
Right.
But I agree with you in terms of, some of those things that you've pointed out. We're actively looking at how to best do that within the House. And so even, for example, your reference point to Healthy Montgomery, since that meeting, we spent maybe 25 to 30% of the meeting doing some brainstorming to talk through those particular issues. We have met as a team internally to think through those strategies and ideas, and we'll be reflecting that back to the committee to be able to vote on and to have some conversation around, how we have things structured. Does this make sense to keep doing this? Because you're right, we don't have within the priority areas. There isn't a priority area that says, here's a rapid response. So, for example, sexual health pops up,
Yep.
or tuberculosis pops up. There's nothing, in place to do that, which is not acceptable. I agree, and so we're being thoughtful, and I personally and professionally appreciate your thoughts on that. I think that will help move those conversations forward.
Mr. Rice.
So I agree with everything that the chair has said to an extent. I think that some of our organizations are specifically equipped with things that will be strategic for us. But there are, and the reason why I supported you, Mr. Chair, when you came up with those initial recommendations is because we have so many generic ones that are floating on the exact same lines of doing the exact same work, that it really doesn't make sense for us to continue to have all of them. And so that spirit and conversation around what you spearheaded some time ago is going to be something that I hope, returning as the ranking member for the Health and Human Services Committee, that we will continue to try to address. And maybe with having some new folks who are looking at this new, as well as a new county executive, there may be some momentum to get us going in the direction that you recommended. I think that it would behoove all of us and help to streamline. So I just wanted to say that in response to what you said. But I wanted to get specific about a couple things real quick from your presentation. I want to talk about STIs, and I also want to talk about low birth weights. And the reason why is because it's something that's concerning and solvable. I've seen through our SMILE program and through the other programs that we've had regarding maternity care and wellness that we've been able to stamp out. But these specifically on these charts are a region. So it's not as if some of the other ones have been interspersed throughout, as Councilmember Leventhal had said, when it came to some of these. But when I look at some of these, they're actually focused in a particular area. And that concerns me more. Again, having read in certain areas, we still need to address. But when they're all pocketed in a region, that's where that tells me something else is going on and we may want to stamp this out. When I look at what's happening with low birth weights, I mean, it's my district. It's Germantown, Boyd's, Damascus, Montgomery Village. I mean, those are all areas that are reflected with a smattering of some of the others that I do agree with Councilmember Leventhal may just be anomalies based on population. But I mean, when I look at those and then look at some that are happening in the heart of Silver Spring, and then some that's happening on the east, but you see that large pocket of red that's there, that's concerning to me. And whether it's that folks don't realize that the access is there to particular programs, or that the programs themselves aren't there and aren't available for folks. So that's really something I want to delve into a little bit more and find out what we can do to beef up, whether it's increasing programming or something, we've got to do something to address that. Same with STIs. I mean, when you look at STIs, again, you've got the Germantown, Gaithersburg, Montgomery Village area, solid red. There's not a single area in that pocket that's not red between that. And then the Silver Spring, Tacoma Park area, solid red, right? And so, again, along those lines, I say to myself, these are things that we need to and can address now. Just as we move quickly with what we did within our school system, within MCPS, when it came to initiatives that I think were great. And so kudos to the chair, Councilmember Leventhal, and Jill Ortman-Faust, member of the Board of Education, who, based on your suggestions and your report, moved forward with some things, and I think were great. I think it's time for the county to now act. We've seen the school system act. We need to do something as well. And so I'm wondering if you have some recommendations about things that we can do to double down, whether it's investing in our minority health initiatives or whether it's beefing up programs within HHS. I'd just love to hear from you as to what your thoughts are about what we can do now, because from my perspective, these warrant us talking to the county executive, just as MCPS did, about doing something immediate, which might involve a supplemental. And so from that perspective, I'd love to hear your thoughts.
Sure. Well, I think and I've been a resident of the county now for a year as well. Part of the challenge, and I can say this specifically for sexual health, less so about maternal health, because I know, and even within sexual health, there have been some initiatives. I know AHP has been working in that area as well, and then in maternal health, multiple agencies from SMILE and AHP to others have been working in that area. Part of the challenge is that and I appreciate the interest and the energy and the passion around these issues from you all and from the folks in the room. The challenge has been able to get the other 1.1 million people in Montgomery County to feel that sense of urgency. And, as it relates to sexual health, there weren't a lot of conversations about sexual health in Montgomery County until recently. Having been the STD director in DC for 2 years and knowing the conversations in the DMV area, Montgomery County was never talked about. And when, as far as engagement around those issues, it was, we talked about it in Prince George's, we talked about it in Baltimore, you talked a little bit in Northern Virginia, but it just wasn't an issue. And so part of the challenge is being able to elevate these conversations to an urgency level where people get that this is a crisis and this is a particular situation that warrants further attention. I am, again, excited about the efforts, Chairman Leventhal and moving getting us across the finish line in terms of increasing contraception access in schools related to sexual health. But even within that was 99% of the conversation, but only 1% as part of the comprehensive strategy to address that. And so part of, addressing sexual health, again, gets back to, do we have access to screening? Do folks have access to treatment? Do folks have access to contraceptive alternatives, not just condoms? What does that look like on a county level? And are those services readily available to people across insurance statuses, across income, across demographics? Are they readily available from a geographic perspective? And so I think changing the culture of complacency seems like a strong word, but I think it's the appropriate word. That we do have health issues in the county, and again, we celebrate and are very happy to be #1 in the health outcomes, but we have a lot of work to do. And I think part of that challenge falls on us to be able to make the case, to, again, provide the data, to highlight and say, no, this is not something to be ignored. This is an issue. It needs to be looked at further to drive those conversations. So that's the global perspective. I think we are, telling that different narrative to get on people's radar, to ring the bell, to raise the alarm about not just sexual health and maternity health, but a host of other conditions. And so similarly, when you think about maternal health, on the surface, you're like, but our infant mortality is better than the state. And, we don't have women dying. I think the analysis over the last, I think it was 5 to 6 years, we had 2 maternal deaths in pregnancy. So when you look at it compared to a DC or a Baltimore, it's not a big deal. So it's easy to say, well, that's not an issue for us. Whatever we're doing must be working because our numbers are better than everybody else. I don't believe that. And so when you change the question, again, where it relates to maternal health, is we change the question from saying how many folks are dying to saying how many people are having complicated deliveries. And complicated deliveries mean potentially complicated pregnancies mean complicated deliveries, which means complicated infants born, which could spill to a whole host of other outcomes and issues. Reframing that question in a different way reveal that there are significant issues. Again, African American mothers 40 times more likely, Latina mothers 20 times more likely to have complicated deliveries. And so highlighting those areas, as you said, your district was red in a lot of the maternal health. And so, for example, the maternal health grant, We Have Babies Born Healthy, and coordinating with the other efforts, SMILE and others within the county, is based upon the provisions by the state grant. We are pilot testing in a couple of zip codes actually that scored high in terms of this to figure out some best practices to do an added layer of outreach. And so while it is focused on African American women in the county, we're trying to look at what other factors might predispose women to having complicated pregnancies, and investing additional resources to go out and find those women, as opposed to waiting for them to come in, but be proactive about finding those women and then linking them to the services that you mentioned that are already in place to say, all right, we've got great outcomes and great success from this program. You need to be a part of this if you're eligible. And then taking those best practices and scaling them up. And actually your district is the area that we propose to do that. And get some data, get some track record in order to be able to continue to apply for those state funds, but then also look at some other alternatives to enhance that, particularly from a funding perspective.
If I could just follow up on this. So you have the resources to do what you've just talked about, because from my perspective, again, and I just want to be real about this and transparent, I mean, it's my district that I represent, and so if there's an issue in my district, then I'm going to fight for us to make sure the resources are there to support something that specifically is affecting my district. And so from that perspective, I just want to understand if the resources are there, great. If we're waiting and hoping that the state's going to put in some funds and help us out, then that's all fine and good, but I'm willing to push for us to ensure that this happens, because when you use the word, and it's important, I think, because I think it's important for folks to understand, even if we are not in crisis stage right now, but if we're on borderline to where it could be a crisis, that's not what we want either, because then it requires so much more work to get us out of crisis than to avoid us getting into crisis, right?
So to your question, I'll be very succinct in this. As it relates to sexual health, we do need more resources supporting after-hour screening and testing. Increased resources to support outreach and education to the community, particularly to young folk. Increased resources to help support disease intervention teams within the public health department to be able to respond more quickly to positive results, to do partner notification, and to let folks know they may be a contact and need to get screening and potential treatment. As it relates to and so in those high point areas, we need more folk to do that. For example, we are in the process of hiring a nurse practitioner in our Dennis Avenue clinic within the STD program, which would allow us to be able to explore having that person go up county and do some hours there. So resources to help support that. As it relates to maternal health, I think we do need more folk on the ground to do that initial outreach and identifying, pregnant mothers. And again, as opposed to just waiting for folks to come into the doors, being able to staff folks to go out. And I could even see this, and this is completely not thought out, so everybody behind me, don't hold me responsible for this, I'm just thinking through it in my head, is creating a network of systems and partnering further with the hospitals to say, figuring out a way when a woman comes into an OB-GYN or their primary care provider with a pregnancy, potentially getting the name and doing some proactive calling out to say, hey, are you linked to services, particularly women who were concerned based upon the algorithm that may be high risk. I think there's additional need to explore some other programs such as home visiting programs as it relates to pregnancy, not only during the prenatal period, but after women have their babies. Because a lot of the pregnancy programs, rightfully so, because we want to make sure that people have healthy outcomes, focus before the baby's born, and then the level of support drops off, because we've got to focus on the prenatal period. But I think an investment in terms of staffing and support to be able to do that in the postnatal period to make sure that not only the child reaches their appropriate developmental milestones, but make sure that the mother also has the support that they need, because potentially she may be having another child. And then, helping mitigate those resources, those influences that may be complicating her life. Because we know that when we have conversations about maternal mortality, even looking across, you can't explain that away by socioeconomic status and education status, so there must be something else going on. As a pediatrician who was 49.999% going into neonatology, the rest, 100 minus 49.9%, decided to go into adolescent medicine instead. Was curious in terms of exploring that and looking at the impact of weathering, collective experience passed down, and the impact of racism and all those factors influencing those outcomes. So I think that's a long answer to say it's a staffing piece, and I think being able to bolster the support within the area health centers in those jurisdictions, I think would be to add an extra layer of benefit to then also supplement the work that's happening, for example, with the minority health initiatives, and being able to help enhance their ability to do the work on the ground as well in a coordinated effort.
Okay. All right. So if you want to know which is the healthiest county in Maryland, the best source for that is a website called America's Health Rankings, which is an initiative of the Robert Wood Johnson Foundation. And they go through all the counties in all 50 states. What they don't do, there's two things they don't do. One thing they don't do is rank the states. So there's another effort from the United Health Foundation that does that, and it's a somewhat different algorithm. They compile, it's similar but not identical. Within the public health field, why is that? Why has no one suggested that somebody ought to rank all the counties in the United States, not just the counties by state? So, here in Montgomery County, look, it's not entirely surprising that we have not much in common with Somerset County, Maryland, right? Somerset County's primary industry, I'm not certain, but I think it's crab picking. The poultry industry is really large. It's a maritime county, historically impoverished African-American population. We are different. We have NIH. We're on the doorstep of the nation's capital. We've got the highest percentage of PhDs of anywhere in America. I mean, we're just not the same. But we closely resemble Westchester County, New York, or Montgomery County, Pennsylvania, or King County, Washington. There are counterpart large urban counties that would give us a better sense of how we're actually doing vis-a-vis a smaller rural county, which happens to be in the state of Maryland, Allegheny County. We just don't have that much in common, even though, we're a small state, but we're a diverse state. And we have higher income and lower income counties and large urban and small rural counties. And why has there never been an exercise that of the 3,100 some counties ranks the healthiest counties in America, not just the healthiest counties in each state, disparate from the healthiest states?
I think that's an excellent question. I don't have a definitive answer to that. But to flip that, that's actually why we attempted to do a deeper analysis of even just the state comparison, because it wasn't enough to tell the story. As you said, as we're having the conversation today, there's clear needs within the community, and we didn't want to just drop it off and again say, yeah, we're number one again. Okay, let's put on our blinders and coast to next year and wait for it to be, are we number one? Or is Howard going to be number one this year? Or are we going to be number one? Right. Because we knew that we needed to do more work. So it would be fascinating to see that analysis. And I think we can, Dr. Lou's busy with a lot of things, but that's one thing that we can think about as we refine the releasing the data to the public, is being mindful of that. Is, I know, for example, in the annual health report, we compared ourselves to the state and the nation, and then the Healthy People 2020 metrics. And that's something we could think about adding in to say, you know, how do we stack up against all the other counties within the country? And even within this, you know, we haven't released any of this data yet. You know, we're still thinking through how we can refine it. That you all are the first to hear this and to see this. And that's something to think about, maybe as another point of reference to see how we're doing.
Yeah. Yeah, I wouldn't suggest that we take on the task of ranking all 3,100 counties, 3,167 or whatever, but just, you know, benchmark ourselves against, try to figure out some comparable counties, you know. Counties of over 1 million, counties adjacent to large cities, something like that. Okay. Next question. So my first question was, I understand that the way you pursued this report was that you took the America's Health Rankings and you stuck to those indicators, the indicators that they identified, and then you delved deeper on a zip code by zip code basis. Okay. How rigid were you in that regard? And so when for example, when you tell me, some of the classifications make sense, like you're dividing up clinical care factors, and the clinical care factors are percent of population employed in healthcare, after-hours emergency department visits, hospitalizations for preventable conditions. That makes sense to me. I get that. I understand the linkage there. Quality of life, on the other hand, if you ask me, and I'm you know, fairly well educated in public health, more than, you know, the layman on the street, what would be the indicators that you would look for to define quality of life? They wouldn't be these indicators. The indicators that, I'm looking for which page quality of life is on. Inpatient and ER hospitalization rate, mental health related hospitalization rates, low birth weight deliveries. I'm sorry, that I would never think of those. If you asked me off the top of your head what indicators would communicate quality of life, length of life would be one, wealth would be another, access to leisure would be another, access to parks and recreation. I mean, there would be a whole lot of things that we talk about at the Healthy Montgomery Steering Committee as relevant factors that make up quality of life. I mean, low birth weight deliveries is an indicator of a lot of things. It tells you the quality of life of those infants. I mean, I can sort of make the connection, but it doesn't intuitively ring true to me. So did you come up with that, or were those the categories that the Robert Wood Johnson Foundation exercise used, and you just stuck with those because that's what they used?
So and actually, if you go back, if you see, where's the slide? We're getting there, 1 second. So actually, the criteria were tweaked from the Robert Wood Johnson rankings. So we did not come up with this algorithm on our own. It was 2 steps. So you had Robert Wood Johnson.
That's the answer then.
And then I can actually send you a link to the paper that goes through. Dr. Nagasako, they did this analysis on all of the counties within Missouri. And what they did is, because they tried to use more local, relevant, and specific data, they relied heavily on hospitalization data and things like that were better approximations of local activity. And so they created the new algorithm that tweaked some of these measures that Robert Wood Johnson used that they thought would be better approximations for local entities. And that's where the Pearson coefficient came from, their model. And so we borrowed their model and their method to use here in the county. So it wasn't something we did.
Thank you. That's the answer. So you wanted to pursue a statistical exercise. You wanted to do it. You have to make some assumptions. Right. Like I said, what comes out of the computer depends on what you put into the computer. So you stuck fairly rigidly to a framework that already existed that other researchers had used. Okay. It's your turn.
Well, I do want to jump on that, though, because it's interesting. If you talk to constituents will assert that, and again, I know it's all relative. Councilmember Leventhal will tell you this, and he lives in the Tacoma Park area, so folks there will say that their life is rough, and, you know, but, I mean, when we look at anecdotally what people's complain about when it comes to all the other things that are associated with quality of life that Councilmember Leventhal talked about, whether it's traffic, whether it's access to jobs, whether it's access to quality healthcare, quality schools, all the things that folks talk about. We get constant complaints from East County and Up County. Everybody says Down County and, Bethesda, Chevy Chase, Potomac, they have everything and nobody else does. And if you look at the list here, in terms of quality of life in the map, I see Up in Western County is in the red. I see that the eastern part of the county has some splotches of red, but then is a lot in the yellow, and Down County's in the blue. So again, even amongst some of those things that Councilmember Leventhal is exactly right, that you wouldn't typically say it's interesting to me, that it still follows that same sort of pattern that anecdotally we hear. Now again, like I said, I want to give deference because I know that we hear that from all of our residents, that, but when it comes to, some of the things that we know heavily impact quality of life, whether it's access to quality transportation, right? And time spent on roads going to and from jobs, all the things, access to quality restaurants and other kinds of amenities and things that are there. Those things aren't there for the up West County, east part of the county, and that's where we see some of these yellows and reds at. And so I do think it's interesting to me that even with the things that you picked, that they're still following those same sorts of trends and how they might be interplayed together in terms of having an effect. Does the stress of not having a job that you feel is a high quality job and is great for you and having a very long commute and not having access to a lot of the things that somebody else does that then contribute or help to contribute to the low birth weight of a child? I would say so. I would say it contributes to higher blood pressure. I would say it contributes to other kinds of health issues that have then an impact on your well-being as a whole and healthier outcomes. So yes, I would say that they are tied together. So it's interesting to me. I agree with what Councilmember Leventhal is saying, but it's interesting to me in terms of how they tend to follow each other when I just look at this in terms of what I know about the county. So just interesting.
And I will say, I'm loving this conversation because the fact that, we're this is great. We're having these conversations to talk about, we all acknowledge that there are issues and that need to be addressed, and we're talking about the nuances and how to best present it as opposed to presenting it all. So again, I am thankful for the space and opportunity to have these kinds of conversations because I think these are the conversations that I think will lead us and push us, related to public health. Again, I can't speak for other areas, but these are the things that I think will, in the level of engagement to push and move the agenda forward. The hope is that when putting this data out there, it will, spur these conversations, as you said, to talk about, well, wait, this kind of aligns with what we're hearing in other areas, and it actually also aligns with education, and how do we look at this together? And so that's the purpose behind, again, putting it out there to incite these conversations and then see what the future analysis holds. So thank you again.
Okay, on your 5th slide, Envisioning Equity in Montgomery County, Maryland using data is convening workshops with multi-sector stakeholders. So Envisioning Equity in Montgomery County, Maryland using data, and you mentioned you're going to have one of these on October 20th, I think you said?
Yes, the first one was September 7th.
What is this, Envisioning Equity in Montgomery County, Maryland using data? Is that an ongoing exercise that will produce more products like these? Is it an activist entity that will implement new approaches to the distribution of resources? I had not heard. I'm chairman of the HHS committee. I was co-chairman of the Healthy Montgomery Steering Committee until a few months ago. I hadn't heard of this. What is that, Envisioning Equity?
So Envisioning Equity is a component. This is what we propose as our, let me go back up here so I can get, where are we? So our proposal for the Kickstart grant, so to give some background to that, it's a small grant from Robert O. Johnson, and the purpose is to fund educational outreach to teach data. And so
Okay.
what we proposed doing was having
So what it is it's a program to fulfill the requirements of a grant that you got.
to fulfill the requirements of the grant,
Yeah.
but to use that again as a conversation starter to implement,
Yep.
to discuss a more large-scale, sustainable effort to continue that thought.
Okay. I don't want to embarrass you, so I'm not going to ask them to respond to the question, but I'm going to, well, I'm curious whether the 3 minority health initiatives represented here feel that they are incorporated in that effort or knew about the effort. So I'm just going to let the question hang out there, and I just think it's something for you to ponder. The other, which actually gets to another issue, which is the organizational chart. They don't report through you. They go directly to the director, which I get. I mean, there's benefit to that, right? I mean, probably they want to go directly to the county executive. Probably
They're part of the Office of Community.
they are,
Betty-
under Betty Lamb. And that reports to the director. It doesn't go through you.
No.
And that's, I think, maybe a misplaced box on the organizational chart. I think that's also something to think about in the future. I mean, they are public health efforts, and they really aren't, I mean, they're community organization efforts, but they're community organization efforts geared to public health. So, so I'm ready to close. I'll close where I began, which is I think this is very useful and helpful work. I think it needs to be more cohesive with the other efforts already underway. It shouldn't, as you continue to fulfill the terms of this Robert Wood Johnson grant, the work ought not come as a surprise to other groups that are working in the same space, and that does fall to you to be a convener of all of these disparate efforts to ensure that the whole is greater than the sum of its parts, and that we're all using the limited resources that we have to try to achieve measurable outcomes rather than scattering those resources on lots of well-meaning but not cohesive efforts.
Sure, that's entirely fair.
Mr. Rice, anything further?
No, sir.
Yeah.
So I did just want to say something about restructuring, because I do think, again, and you started to have this conversation before, that I do think it's worthy for us to rethink how we're going to be attacking the challenges that we do see within this county. I will just say that as a minority myself, as a person who understands that there are nuanced ways in which we've been successful in our various communities at getting out and outreaching to folks and getting trust for them in many cases where community members don't trust government. They don't trust health entities to do what they need to just based on their own experience from other countries or cultural biases that exist, that we do still have to have that woven into whatever kind of structure we have. That's going to be incredibly important for us because I think at the end of the day, to generalize those things means losing out on the specificity that's necessary to get at the things that we're seeing that are in particular communities. So I do want to say that, but I do agree that overarching what we need to do, and Mr. Chair, I think it was your effort in trying to bring some of the entities together under one umbrella anyway to be able to have those conversations as we're working on particular issues. And I recall a few years back when each of the minority health initiatives had programs that they individually were working on, but we saw a lot of opportunity in a lot of different sectors for very different things. But each one was very focused on some things and made great strides in getting those things done. I think it may be time for us in looking at this data to do that again, to really start to double down on some of those efforts led by the data that we have. Before, I have to be honest, it was more anecdotal. It was like, look, this is what we're hearing, right? Now we have numbers to support what it is that we've been hearing for so long. And we can be even more strategic about, instead of just saying, well, we're going to focus on mental health, or well, we're going to focus on TB. Well, we know where the incidents are. So not only can we say we're going to focus on TB, but we're going to focus on it in these particular areas, and that's going to make a difference in terms of making our dollars go farther, right? Something that you had talked about, Dr. Gales, at the beginning, when you talked about this data-driven approach to begin with. And I think that that's going to help us because, again, what it's going to do is it's going to streamline requests that come from our minority health initiatives because they're going to be very tailored in terms of what it is that they're looking to do. But also, I think, is going to get us better results as well because they're so targeted, right? I mean, if we're looking at 20878 and that's the zip code, we should be able to see health outcomes in 2078 right away and see the sort of change, you know, how many hospital visits and how many people are going to the ER, all that kind of stuff we'll be able to get. So this is tremendous because not only is it going to supplant what I think is the support for health-based initiatives, but it's also going to help it to be more aligned with the needs that we're seeing in our community. So I just want to again say thank you. Thank you, Dr. Liu, for your great work. This is going to be tremendous for us in helping us to get to the next level in partnership with some of our community folks who are working hard to really turn back the tide on some of these disparities we're seeing. So thank you, and thank you, Mr. Chair.
Yeah, thank you. I want to be clear with the minority health initiatives. I wanted you here because I do think the work you're doing is so important, and I do think that the targeting by demographics is probably more useful and instructive than the targeting by zip code. So nothing I'm saying about duplication or better consolidation is to suggest that there's a diminished need for the minority health initiatives. I would like to see the minority health initiatives play an even more significant role in targeting and benefit from these data that are available and have been compiled that I don't know if you all were aware of before, you know, Dr. Gales released them, and that we ought to be working more closely together. So we'll look forward to the conversation this evening. I promised we would end by 4 so that we can get to the African American Health Program on time, but I see that Mr. Montez would like to make a comment. Did you want to come forward and say something? Well, you have to come to the microphone and introduce yourself. Yep.
Here's a copy of the paper.
Okay.
Thank you, Mr. Chair. I just wanted to
Introduce yourself
Henry
for the record.
Montez, with the co-chair of the Latino Health Steering Committee. I just want to make the point that there are a number of documents that I think would be very useful in this conversation, not the least of which we presented to you several months ago on the blueprint for Latino health in the county. And we shared information with Dr. Gales about that, and also about a report that we did about 3 years ago on data needs of the minority. It was all the minorities, but we had an appendix for the Latino issues. And so I agree wholeheartedly with your approach about the demographics. I think that's the way to go. The other thing I would encourage is a primary data collection rather than the secondary, at least once, to get a baseline. And then maybe from that point on, a baseline for each of the populations, not just one for the whole county. And then from then on, look at it during the times that we do our community health needs assessments, I think every 3 years, and see and measure against the baseline, not against each other, but against our own baseline. Did we improve as a population in our health conditions and status? And I think that would be, to me, more useful to know what's going on with the populations and what are targeted areas that Mr. Rice was talking about that we need to contend with.
You want to respond to that, Dr. Gill?
Well, I mean, we'd ideally love to get, improve our data collection methods. I mean, we simply don't have the workforce to be able to pull that off. That would be a Herculean effort. And I think we do a good job of consolidating, and I will say Dr. Liu has done a fantastic job in the last year of consolidating access to all of the different respective data sources to be able to approximate as best as we can the most relevant data, and that gets to the heart of it. But, we look forward to, and I think this is one of the asks too, Betty and I have talked about ways of how to streamline, data requests and to pull that off. And we've explored some different strategies in trying to identify some resources to potentially create a position to be able to do that, to have a member of the data team who specifically addresses the needs of the minority health initiatives. We don't have a PIN for that, but that has been something that we have talked about a number of times, and I guess I will put that on my wish list to you, Councilmember Rice, in terms of other items that I will get to you by the end of this week. To do that. But I think that we all agree upon, getting the best data possible. I think to get the baseline primary data, it depends on what the question is we'd be asking, I think is the best one.
Well, you'd have to work together on that.
Right. But, as far as like a lot of the other stuff, the population levels of the hospitalization data, things like that, it would be hard to not utilize the data sources that we can easily pull from to do those. But I think where it's more salient to do so, I think there's an opportunity, but certainly, again, there would need to be an investment in expanding our workforce capacity to do that.
Thank you.
All right. Well, thanks, everybody, for an excellent conversation. Appreciate it very much.
Thank you, guys.